How to perform a bedside endoscopic retrograde cholangiopancreatography for acute cholangitis. These are our disclosures. The objective of this video is to teach a technique of performing bedside ERCP without the use of fluoroscopy in critically ill patients in the intensive care unit. An 88-year-old woman with a past medical history of coronary artery disease, atrial fibrillation, diabetes, hypothyroidism presented to the emergency department with a one-day history of fever, abdominal pain, fatigue, nausea, vomiting, and diarrhea. On arrival, she was in septic shock and respiratory failure. Labs were notable for leukocytosis, cholestatic pattern of liver enzyme elevation, and acute kidney injury. Initial management included intravenous fluid resuscitation, broad-spectrum antibiotics, vasopressor support, and mechanical ventilation. Non-contrast CT abdomen and pelvis showed severe intra and extrahepatic dilatation due to choledocholithiasis, and CBD measured 3.2 centimeters. There was no evidence of pancreatitis. She was diagnosed with acute ascending cholangitis and was admitted to the intensive care unit. Emergent ERCP was indicated. Due to clinical instability and OR unavailability, the patient could not be transported outside of the intensive care unit. Decision was made to pursue a bedside ERCP with stent placement without a fluoroscopy. ERCP was performed within 24 hours of presentation to the emergency department. A duodenoscope, sphincterotome, guide wire, and a plastic biliary stent are needed for the procedure. The patient was placed in the left lateral position. Propofol was administered for sedation per the intensive care unit. Therapeutic duodenoscope was used, which showed a bulging ampulla in the second part of the duodenum. The bulging major papilla was engaged with the sphincterotome, expressing sludge and debris. The guide wire was passed into the bile duct and the sphincterotome was used to cannulate the bile duct over the guide wire. A sphincterotomy was performed and the sphincterotome was removed over the guide wire. A 10 French by 7 cm plastic stent was placed 6 cm into the common bile duct. Stent position was then verified using an abdominal radiograph. There was no immediate procedure-related complications. Since fluoroscopy is not used in this technique, other methods to ensure that biliary cannulation is successful are the following. At the beginning of the procedure, it's important to angle the sphincterotome between the 11 o'clock and 1 o'clock position. The wire should go into the bile duct easily at least 15 centimeters. If it does not, then the cystic duct or pancreatic duct may have been cannulated. Aspiration of bile and sludge from the sphincterotome can also provide reassurance. Our institution has had success in performance of bedside ERCP in select patients with acute cholangitis in the ICU. From 2007 to 2012, 8 patients underwent bedside ERCP. ERCP with endoscopic stent placement was therapeutically successful in 5 out of 6 patients with normal anatomy, but failed in 2 patients with altered anatomy. Rescue ERCP with fluoroscopy was required in 1 patient. There was no post-ERCP acute pancreatitis or other procedure-related morbidity. Biliary decompression in acute cholangitis is recommended within 48 hours of presentation. Clinical instability and logistical hurdles may cause delays in performing ERCP. This case illustrates that bedside ERCP can be successfully performed without the use of fluoroscopy. Simple imaging modality such as portable X-ray can be utilized to confirm the stent position when fluoroscopy is not available. The goal of bedside ERCP is to provide rapid biliary decompression when the patient cannot be transported out of the intensive care unit or when an OR is not available. Additionally, the goal of this technique is to intervene quickly to place a biliary stent. There are a few case reports and case series that have reported urgent ERCP with stent placement without fluoroscopy as a feasible option in ICU patients who presented with biliary sepsis and biliary pancreatitis. Aside from abdominal X ray, ultrasound has also been used to confirm the stent position shortly after the procedure. In conclusion, this is a video illustration of one technique of performing bedside ERCP without fluoroscopy. Bedside ERCP is a technically feasible and useful method in critically ill patients who are unsafe to transport or where logistical hurdles such as OR unavailability prevent a timely ERCP. Thank you.